No disclosures. Okay, so here's the scenario. It's a Tuesday afternoon. Dr. GI calls me up and says, I have a patient in the hospital who's been there for 4 days on IV steroids with fulminant colitis. Go see the patient. The first thing that a surgeon thinks, and I know you don't think surgeons think too much, but the first thing that a surgeon thinks in his or her mind is, the standard of care, I want to do a laparoscopic ilioanal two-stage iliopouch anal anastomosis with a temporary ileostomy. The reason we want 2 stages in laparoscopy is that it had the short-term results show acceptable low surgical morbidity and mortality. The long-term results, high patient satisfaction, excellent quality of life, no permanent stoma, nice scar, etc. That's the way surgeons initially, when we walk into a room, obviously we hear initially what's the GI doc would like, we're thinking this is what we want. Obviously we don't do this all the time. And just to reiterate what we do surgically, this is the ileal pouch. This is the terminal ileum, which has been divided over here. This is the ileocolic artery, or branches. What we do is we stretch this ileum down to get it to the pelvis and to the anus. That sometimes is a reach. Small bowel normally lies here in the abdomen. Sometimes it's a little bit of a reach to get it down. And then once you do that, you actually then make the J pouch, as shown here with a stapler. You can see that we frequently have to do mesenteric divisions of vessels, and the reason that we do that is to get additional length, and I'll tell you why this is important in a minute. There are, however, other options, and as surgeons, although again many of you don't think that we think too much, this is where critical surgical thinking comes in, because there are other options we have to do. Sometimes we can't do laparoscopy, in which case we need to do an open iliopouch anal anastomosis. Sometimes we have to do a subtotal colectomy and ileostomy, total proctocolectomy and permanent stoma, a total colectomy with an ileorectal or even a continent ileostomy. So what are these? This is a subtotal colectomy, and what you do is you divide the ileum where it meets the ascending, or where it meets the cecum. You take the entire colon out, as shown with my pointer, and you leave the rectum. You usually staple it off or some variation thereof. The advantage of doing this is that it's quick, little morbidity, no anastomosis, and no pelvic dissection. And all of those are very important sometimes in these very ill patients who are sick with fulminant colitis, which I'll get back to in a minute. There are, however, other options additionally. You can take the entire colon and rectum out and give the patient a so-called Brook permanent ileostomy. You can also do a variant of that where you can do a coke pouch or a continent ileostomy. I've already talked about the ileal pouch anal anastomosis, and rarely nowadays you can leave a little bit of the rectum, particularly if it's compliant and minimally inflamed, and consider doing an ileorectal anastomosis. So how do we decide what to do? Okay. What we do is we look at the patient and we look at what we see preoperatively and we look what we see intraoperatively. And preoperatively, there are patient-specific factors that guide our decision and disease-specific issues that guide our decision. And let's discuss these in a minute. In terms of patient-specific issues, obesity, age and coexisting medical morbidity, anal sphincter tone, fertility, a patient-directed decision, which I'll get to in a minute, and prior abdominal surgery. So why is obesity such an issue for us? Well, if you want to do a laparoscopic two-stage iliopouch anastomosis, which I mentioned is the gold standard, it sometimes is difficult to do because it's very difficult to get a pneumoperitoneum for the laparoscope. There's impaired visualization of normal anatomy when you're doing laparoscopic surgery. The stoma creation in these patients with big abdominal walls could be quite thick. In addition, the small bowel mesentery frequently limits the J-pouch mobility. Remember I told you before that one of the biggest issues we have here is getting the J-pouch, which lies in the abdomen, down to the anus, and we frequently have to take mesenteric division to get those, to divide the mesentery in a way to allow the small bowel to reach. That's very difficult in a mesentery that's very thick. And in addition, if you're contemplating taking up the rectum in these very obese patients, a thick mesorectum can be quite difficult. And the studies there's many studies that have looked at the influence of obesity on ileal pouch surgery. This is just one representative study from last year. And you can see any complication rate was significantly higher, any pouch complication rate was significantly higher, anastomotic pouch stricture was higher, inflammatory pouch complications, and pouch fistula. So what I'm basically saying is obesity is not a patient that you want to rush in and do a two-stage iliopouch anastomosis. And you should consider, in those situations, doing a subtotal colectomy, leaving the rectum in place, give the patient an endoileostomy, and tell the patient go home. and come back when you lose weight. These patients are very motivated to lose weight because not only are they off medication, but what I tell them is next time you're looking at a cheeseburger, make sure you look at your ileostomy first. They'll be extremely motivated to try to lose weight. What about patient age and comorbidity? Increasing age, just like any surgery, is associated with a higher surgical complication rate, and we know that there's poorer functional results after an IPAA. Patient comorbidity is associated with higher surgical complication rates, so in these patients, you might consider, and we as surgeons consider, maybe doing a total proctocolectomy right off the bat, one-stage operation, end ileostomy, that's the end of it, and not have to worry about all the potential pelvic complications that may ensue with an ileal pouch surgery. One option also, particularly in an older patient, is to consider a subtotal colectomy and a permanent stoma, acknowledging that the rectum will be left and surveying it if necessary to make sure the patient doesn't develop cancer. What about anal sphincter tone? By definition, you're taking small bowel contents down to the anus, very liquid contents, and although there's some solidity to the contents, it's not exactly a solid log bowel movement from when they used to have their colon functioning. You need, therefore, a good sphincter tone to have a good functional result after an IPAA. And tone may be reduced by a lot of things, including age, if they've had prior anorectal surgery, for example, a hemorrhoidectomy, or if many women have had vaginal deliveries, with episiotomies or even forceps deliveries that can interfere with anal sphincter function. And in those situations, consideration of a total proctocolectomy with a permanent stoma or a continent ileostomy might be considered if the patient doesn't want an external appliance. What about fertility? Very, very difficult problem to deal with. It is known that when you do an ileal pouch anastomosis, because of the development of peritubular adhesions, that female fertility is reduced. If you look at the general population, this is the data that we usually quote to our patients. The average woman, if you like, in the United States has an infertility rate of 12% for various reasons. I'm not going to go into all of those. But after an IPA, it goes to about 18%, which granted is a 50% increase. However, it's still relatively low, and thankfully the vast majority of women still get pregnant after an IPAA. But one of the things you could consider doing in those patients, if the patient is very pregnancy phobic, not phobic meaning they're very focused on being sure they get pregnant, is do an initial subtotal colectomy. Now, what's the evidence that just doing that helps? Well, we don't have anything in ulcerative colitis, but we do have some data in FAP. And if you look at the FAP data, which also those patients undergo ileal pouch surgery, if you look at the solid black line here, this is FAP before operation. This is the cumulative incidence of pregnancy. But if you compare that to the FAP after IPAA, this light gray area, look how reduced it is. But what's interesting is if the FAP patients, after just an ileorectal anastomosis, i.e. no pelvic dissection, the fertility rate is much better. In fact, it almost parallels the fertility rate of the patients who have been non-operated on. So this has given the impetus to, in young women who are having the surgery, consider the use of an initial subtotal colectomy, let the patient, in endoleostomy, let the patient live with that, let the patient have her family, and then after that is done, come back and do an ileal pouch surgery at that point. What about patient-directed decision-making? This obviously is extremely important. They may, they're sick, they've probably never even heard of surgery, or maybe they have, they're not sure exactly what it means. All of a sudden, the gastroenterologist shakes his or her hand and says, you need surgery. We walk in, and we're talking all this jargon that, quite frankly, is going over their head. A lot of times they can't decide what to do. What you can do, and what surgeons decide in that situation, is instead of doing a two-stage laparoscopic ileal pouch anastomosis, we'll say, let's do an initial subtotal colectomy and let the patient live with the ileostomy for a period of time. That allows the patient to decide whether or not, in fact, they like it. If they like it, then at some point in the future, you take out the rectum because it's a potential cancer preparation, but it can be, or it could be surveyed theoretically. But at least they have the opportunity to live with the end stoma and decide what's best for them. Some patients just prefer to have a one-stage surgery, in which case you should do a total proctocolectomy and a permanent ileostomy or a continent ileostomy. And again, that's a patient preference. Maybe they've had a friend that's had it, or they themselves have read about it, and certainly that would obviously influence the surgical decision-making and what to do in these patients with fulminant colitis. What about prior abdominal surgery? Adhesions may limit our laparoscopic approach, and certainly we can convert to an open approach. That's sometimes it can also itself be difficult because of adhesions. Usually what we do as surgical evaluations, if a patient's had previous surgery, if we could, we'll stick a laparoscope in initially and see what the adhesions are like. If they look like they're acceptable, we'll continue on with the laparoscopic ileopouchial anastomosis. If it looks the adhesions are formidable, obviously we'll convert to an open procedure. In addition, prior surgery may also preclude the ability to even do an ileopouch surgery. Sometimes adhesions may limit the ability of the small bowel to be mobile enough to reach to the anus. If patients had previous small bowel resection, potentially massive resection for something completely unrelated to IBD, they may end up with severe diarrhea, and even, as I mentioned, the inability to even make the J-pouch. And certainly if they've had a previous right hemicolectomy, where sometimes that very important artery, which I showed you on the initial schematic of how to make the ileal pouch, sometimes that's been sacrificed, in which case the ileal pouch itself is essentially impossible to make. So I've talked about patient-specific issues that guide our therapy. What about disease-specific issues? Well, the type of colitis, which we'll talk about, malnutrition, abdominal complications, and preoperative medical therapy, which itself is very controversial. What about the type of colitis? All of us know that IBDU is a disease where you have inadequate criteria to define or at least definitive the distinction between ulcerative colitis and Crohn's disease. It seems to be more common in these particular patients we're talking about in fulminant colitis. The outcomes of IBDU, however, are controversial. Some of us, for example, myself, have published results that look very much like so-called pure ulcerative colitis. Others have not suggested that and actually found that there's a higher incidence of peritoneal complications, Crohn's disease, and even pouch loss. So because the results are variable, one option to consider, we do, at least as surgeons what we do, is we'll do an initial subtotal colectomy to try to get the colon in our hands and send it to our pathologist, who may be able to define for us whether or not this in fact is Crohn's disease or ulcerative colitis. Quite frankly, in the olden days, when there wasn't the general advent the general availability rather of colonoscopes, and everyone and their mother were getting 17 colonoscopies before surgery, this actually used to be somewhat of an important fact, but important maneuver rather. But nowadays, with multiple preoperative evaluations, including small bowel evaluations, capsules, double balloon enteroscopies, et cetera, and obviously colonoscopy, the added value of performing a subtotal colectomy just to look for pathology to help guide you in terms of what you should do surgically is, in my opinion, of little value. Malnutrition is a known risk factor for postoperative complications in all surgeries. Particularly poor oral intake for greater than 14 days is associated with higher postoperative mortality. The role of preoperative TPN in this disease is controversial. Some of us believe that it's useful, just like in esophageal and pancreatic surgery, to try to make the patient a better surgical candidate and tank them up and get their albumin up before operating on a pretty significant surgery. Others of us believe, and there's some data out there to suggest you're not doing very much by giving them that, and in fact all you're doing is causing catheter-associated line infections. So it is controversial, but again, if you have a patient who's malnourished, and there's many different ways to define that. You can look at albumin level, you can look how sick the intestine feels and looks on the inside. One of the ways we sense it in the operating room is if you see body wall edema. If you see body wall edema and abdominal wall edema as you're making your incisions, they usually suggest that the tissues themselves are not good tissue for an ileal pouch at that time, and you should consider an initial subtotal colectomy. Again, the advantage of that, no stoma, although there's a stoma, no anastomosis and no pelvic dissection, because you think that these patients are poor surgical risk and may not be able to heal properly. These are obviously abdominal complications of the disease which require emergency surgery, bleeding, perforation, megacolon. In those situations, almost invariably, these patients should have an initial subtotal colectomy and ileostomy and forego what we consider, again, the gold standard, which is laparoscopic two-stage ileopouchial anastomosis. Now, what about something that's particularly important to this audience, and that is the effects of preoperative medical therapy on postoperative morbidity? There is no question that steroids are bad. That clearly affects our wound infections, clearly affects anastomotic healing. Immunomodulators, not really as well studied, but probably 6-MP, for example, has probably little effect. We've also looked at, actually with Dr. Michelese, we have a paper that's looked at cyclosporin, and there's probably very little effect, if any, of cyclosporin on postoperative morbidity in these patients. What about biologics? Everyone and their mother now are getting biologics in this disease before we see them. This is a summary of some of the somewhat older data looking at anti-TNFs and surgical morbidity. And what I'd like to show you is if you actually look at the postoperative effects here in the last column, the gentleman to my right, okay, and the gentleman to my far left were senior authors on the first two papers, on those papers that you see. And they actually showed there was a higher incidence of infectious complications and a higher risk of pelvic sepsis in these patients. And that suggested to them that maybe a three-stage ileopouchian anastomosis might be the way to go in patients who came into surgery on anti-TNF therapy. However, not all of us, including this paper, which actually we wrote, had that effect. So this is very controversial. And one of the reasons it's controversial is the way the studies have been done. They're all retrospective. There is still yet a good prospective study, although the Puccini trial is a study that many of us are involved in, and hopefully will answer this question. You can see the patient numbers were relatively small, okay? The infliximab dosing was very variable, up to 12 months even after surgery in our paper, which you can argue obviously was not biologically sound. So because of all of these, it's the effects of anti-TNFs on postoperative outcomes in ulcerative colitis are to this day still unknown. So one of the things that we did is we actually tried to look at serum levels. Everyone is getting serum levels now to guide their therapy, which many of you know, to actually guide therapy. So the question is, could these levels be used as a surrogate of effect? In other words, can you measure the level just before surgery, and would that therefore give us an idea of how much TNF was in the blood? And would that affect morbidity of the patient? It makes sense. So what we did is we looked at this. This was published earlier in the year. And if you look, there's a dose association between postoperative morbidity and increasing levels of TNF. Okay, this is in Crohn's disease. Now, if you look at this, you say, all right, well, we're not really, although we could be talking about Crohn's disease, we're mainly talking about ulcerative colitis. In ulcerative colitis, we didn't see it as much. And the reason we didn't see it as much is that it's very hard to get these levels up in an ulcerative colitis patient. And the reason for that, as all of you know, is that when these patients are fulminant, they're pouring all of their protein, including their TNF, into their gut. And that's why it's very difficult to get levels up in these patients. So it's interesting to hypothesize that instead of actually doing a routine use of a three-stage procedure, which the gentleman on my right and the gentleman on my far left recommend for patients who are ulcerative colitis patients who require IPAA, maybe we can measure the levels just before surgery to guide the therapy. And for example, if their level is low, i.e. very little biologic effect at that particular time, maybe a two-stage ileopouchian anastomosis might be worthwhile. We should also consider the time away from surgery, the time surgery away from biologic dosing, the liberal use of temporary stomas in these patients. And one of the things that I like to promote is the concept of rethink preoperative use of biologics. Many of you, and many gastroenterologists in general, when they're confronted with a patient with ulcerative colitis who's potentially facing surgery if they're on immunomodulators or steroids, think, you know what, let's just try infliximab, let's just try an anti-TNF. But that's okay, but I think it's important, beside the cost and the potential side effects of the drug, you should also be thinking of the downside or the downstream effect, because if that patient needs surgery, there is clearly, or maybe rather, a negative effect of these drugs on postoperative morbidity and actually may also affect what surgical procedure the patient has. What about intraoperative issues? Unexpected findings. Sometimes we've done multiple CTEs and DBEs, etc. We still see small bowel inflammation above the terminal ileum. We see creeping mesenteric fat that suggests Crohn's disease. Those situations, an initial subtotal colectomy should be done to allow for adequate diagnostic evaluation. How about if there's a cancer found? That sometimes occurs, even though these patients have been screened multiple times before surgery. In general, you don't want to do an ileopouch in a patient with a suspected cancer or a cancer itself, because you don't want to have pelvic sepsis, which would then limit the ability of our oncologists to treat them and to treat the patient with chemotherapy after, which obviously the cancer is the primary problem. In addition, if these patients have an ileostomy, which frequently is higher up in the stream than a typical Brook ileostomy, you can have fluid shifts related to the chemotherapy, which can cause profound diarrhea. And finally, sometimes at the time of surgery, the small bowel mesentery is thick. Sometimes it's related to steroids and other medications, again, sometimes related to weight. And in those situations, an initial subtotal colectomy is indicated because you literally just cannot get that small bowel down. You cannot adequately divide vessels to get mobility of the small bowel and the J-pouch into the pelvis. So in conclusion, the LAP IPAA in 2 stages is the gold standard. That's the way surgeons think initially when we get a consult. An open IPAA or a LAP or open subtotal are fallback operations for various reasons which I mentioned. Uncommonly performed nowadays, total proctocolectomy and permanent ileostomy or continent ileostomy and an ileorectal anastomosis. And as I said, both patient and disease factors significantly influence these decisions, both before the operating room and at the time we operate. Thank you.